Yeah, Anusha, can we start?
Yes, ma'am.
Okay, let us start then.
Recording in progress.
Hi everyone, Dr. Chithra here, your mentor at StudyMEDIC and StudyMRCOG. And as promised, we are back with our RRR series to help you to clear the Part 1 MRCOG exam. Today, we would be seeing a very important topic from the module anatomy. All right. So the agenda for this session today is to learn the anatomy of the female reproductive tract and to solve related SBAs. Now, before we begin, just a gentle reminder to all of you that the module anatomy, it is a part of your paper 1 and it forms a very huge chunk. So expect somewhere around at least 25 questions from anatomy. And in anatomy also, nowadays the college is more focused on asking you questions related to the reproductive tract or related to the abdominal wall. They are trying to focus on the aspect of anatomy that would help you as a clinician in your field of obstetrics and gynecology. So let us begin with the uterus. Okay, so uterus, we know it is a muscular organ. The shape is that of a flattened pear. The size in the non-pregnant state, it measures 8 by 5 by 3 centimeters. Now the uterus, there are two main parts. You have the body of the uterus and you have the cervix. In the body, you have the fundus, and then you have the body, and then you have the cervix. In the cervix, there are two parts, supravaginal part and the vaginal part. Now the fundus, if you see at this picture, it is convex and it is covered by peritoneum. Then the body, it tapers downward from the fundus and it is flattened in the anteroposterior direction. And then here you have the isthmus. Now the isthmus, the lowermost part of the isthmus, it forms the lower uterine segment, especially during labor. And then you have the cervix, two parts. So this is the supravaginal part of the cervix, and then you have the vaginal part. You have in between the internal cervical os and the external cervical os, you have the endocervical canal. Then from the fundus, you have the uterine tubes, the fallopian tubes, which open out into the peritoneal cavity. The important part that you should be remembering here is about the peritoneal coverings of the uterus. So you have the peritoneum, which is covering the urinary bladder. From there, it forms the utrovesical pouch, and then it turns on and covers the fundus of the uterus. So this part, the lower uterine segment, the supravaginal part of the cervix and the vaginal part of the cervix, this is devoid of any peritoneal covering. That is the most important thing to remember, because it could be asked as an SBA to you. So what is the SBA that they had asked in one of the exams is that when you are doing a lower uterine segment cesarean section, which is the structure that will help you to differentiate the upper uterine segment from the lower uterine segment? The options that were given were the uterosacral ligament, round ligament, UV fold of peritoneum or the utrovesical fold of peritoneum, broad ligament, and ureters. Now, all of us are working obstetricians. We all know that whenever you are doing a lower uterine segment, a cesarean section, after you have opened the peritoneal cavity, we open the UV fold of peritoneum. Only after the UV fold of peritoneum is opened can we get access to the low uterine segment. So this is the structure that will help us to differentiate the upper segment from the lower segment. So that is the correct choice, or the option C, that is utrovesical fold of peritoneum. That is the correct option here. Okay. So in this way, they're going to ask you questions that are related, or they will ask you something that is related to clinical anatomy. Okay. Now, in line with the uterus, we have to know something about the supports of the uterus. So basically, there are the ligaments which help to keep the uterus in place, and also basically the anteversion and the anteflexion of the uterus. That also helps to keep the uterus in its proper position. So anteversion means the angle of the uterus with the vagina, and anteflexion means the angle of the fundus and upper part of cervix. These two angles, they help to retain the normal position of the uterus. And then you have three ligaments. So one is the pubocervical ligament. In this picture, if you see, this is a U-shaped ligament, as the name suggests. So I'll tell you a brief orientation. This is the cervix, this is anterior part and posterior part. So this is the bladder and this is the rectum, and somewhere here you will have the symphysis pubis. So this is the pubocervical ligament. It looks like a U-shaped ligament. As the name suggests, it comes from the symphysis pubis or the pubic bone, and it attaches onto the cervix. And when it is doing this, because it is U-shaped, it supports the bladder or the neck of the bladder. Okay. This is inserted onto the cervix. Then laterally, these are the transverse ligaments, also known as the cardinal ligament or McInrod's ligament. These are also important supports of the uterus. The most important support is the ligament which is posterior. This is called as the uterosacral ligament. Okay, as the name suggests, it arises from the uterus, the posterior part of the uterus, and then it is goes posteriorly backwards, encircles the rectum, and it is attached to the sacrum. This forms a very important part or a support of the uterus. So remember, the three ligaments that help to support the uterus, they are the pubocervical, transverse cervical or the cardinal ligament, and the uterosacral ligament. So you have a 70-year-old lady. She has had 7 vaginal deliveries, and she came with a history of a lump in the vagina. When she was examined, she was found to have a uterovaginal prolapse, which is the ligament that is most likely injured. Remember, she has had 7 vaginal deliveries and she is having prolapse. So one of the ligaments that is supporting the uterus obviously has been injured. So in the options, you were given the round ligament, broad ligament, uterosacral ligament, inguinal ligament, or all of the above. Now, if you remember the previous slide, remember the round ligament, broad ligament, they do not play any role in supporting the uterus. Inguinal ligament is in no way connected to the uterus. So the obvious choice that you have is the uterosacral ligament. So that is the correct option. All right. So this is the option is the uterosacral ligament is likely to be injured, and that has given rise to uterovaginal prolapse. Okay. Now the next part that you should remember is about the cervix. So there are 2 parts of the cervix, supravaginal part and the vaginal part. There are 2 openings, the internal os and the external os, and in between that you have the endocervical canal. The commonest question that is asked about the cervix is what is the ratio of the uterine cervix to the fundus, either before puberty, like at birth, during puberty, during the reproductive age group, or at menopause. So remember, before puberty or at birth, because of less amount of estrogen, the fundus is relatively very small as compared to the cervix. So before puberty, the uterus is, if the uterus is 1, the cervix is 2 times that of the fundus or the uterus. As estrogen increases in the body of the uterus develops, and during the reproductive age group or from puberty onwards, the fundus or the body of the uterus corpus is 2 times that of the cervix. This continues to the reproductive age group. Then, after menopause or in the perimenopausal age group, when there is less of estrogen, at that time the uterus atrophies, and then again the uterus becomes one and the cervix becomes twice that of the uterus. So these are the important ratios that you need to remember about the uterine body and the cervix. Another important thing that you should be knowing is about the blood supply. So you should be knowing blood supply not only of the uterus, the vagina, and the ovaries as well, because there is a lot of applied anatomy that comes into play here. Normally, what happens is this is reference from Gray's Anatomy. There was a question asked about this in the exam. So we know that the main supply to the uterus, it comes from the uterine artery. Okay, more than 90% of the supply to the uterus comes from the uterine artery. Now, 90% comes from the uterine artery, whereas the rest of the blood supply comes from 10%. So if you have a good look over here, see what is happening. Okay, this is the ovary. Okay, we know the ovaries, they have a direct supply from the abdominal aorta, the ovarian artery. Now, this ovarian artery, if you have a good look here, it is supplying not only the ovary, but it is also supplying the tube. Okay, and there are anastomoses between the uterine artery and the ovarian artery. So one of the important SBAs that was asked was how much part of the uterine supply comes from the ovarian artery. So it is around 10% roughly. Another important question that was once asked was that there was a lady who has undergone a lower segment cesarean section, or no, she underwent a normal vaginal delivery. She developed atonic PPH, which did not respond to your medical line of management. They tried to put the brace sutures, but nothing helped. And finally, they decided that they will go ahead and do devascularization of the uterus. So the question asked was that in addition to ligation of the uterine artery and the anterior division of the internal iliac artery, which is the artery that you have to ligate to prevent further blood loss. The choices given were like you have to ligate the posterior division of the internal iliac, you have to write the superior vesicle, inferior vesicle, pudendal, and one choice was ovarian. So if you have been following closely and you have listened, and if you see this part here, and you can see that there is a good anastomosis between the uterine artery and the ovarian artery. Remember that you have to ligate the ovarian artery as well, because if you ligate only the uterine artery, the blood supply to the ovaries, it comes directly from the abdominal aorta. And this ovarian artery is likely to keep on pumping blood into the uterus, and the lady will continue to have PPH. So in addition to ligating the uterine artery and the anterior division of the internal iliac artery, during devascularization, you also have to ligate the ovarian artery. The next question that could be, because it is related to the uterus, so at what level does the ovarian artery arise? Remember, it arises at L2. It is not only the ovarian, it is in general the gonadal arteries. So even the testicular arteries, if they ask you, it arises from the level L2. Okay, this is the pictorial representation. Now, another odd question that has been asked many times is, which is the artery that supplies the distal portion of the round ligament of the uterus? So the options were uterine artery, ovarian, inferior epigastric, superior vesicle, or vaginal artery. Now remember, the artery that supplies the distal portion of the round ligament of the uterus, it is Samson's artery. If they ask you, it is Samson artery, and this artery, it is a branch of inferior epigastric artery. So for the round ligament, the buzzword to remember is inferior epigastric artery or Samson artery, because it is a branch of the inferior epigastric artery. Okay, now coming to the innervation of the uterus, cervix, ovaries, and vagina. Very commonly asked question, and where it's always a source of confusion. So you have the 16-year-old girl who has come into the A&E with complaints of lower abdominal pain, and she has pain in the left medial thigh on the left side. She was examined, investigated, and she was found to have an ovarian mass. So now, obviously, this ovarian mass, it is causing irritation. So they're asking you, this pain, it will be felt through which nerve segment? Options are T10, T12, L1, L2, and L4. There is a lot of confusion always. Many of the students choosing the option T10. Okay. Now remember that the peritoneum that supplies the nervous supply of the peritoneum that covers the ovary, it comes from L2. L2 also is one of the nerve roots of the obturator nerve. Okay, obturator nerve, the nerve roots are L2 to L4. And obturator nerve, being more of a sensory nerve, the pain that is felt on the medial thigh, okay, that is a referred pain from the ovary. So the correct option here is L2 because it is the obturator nerve which is causing the pain in the medial part of the thigh. Remember, ovary does not get any supply from T10. Okay. You can pause the video here and you can have a look at the nerve supply of the uterus, the cervix, vagina, and the tubes. The thing that I want to highlight here is remember for the ovary, the sympathetic supply comes from T12, L1, and L2. There is no supply for T10. So for the ovary, there is no question or there is no option like T10. Okay. Now remember, for the uterus, the supply comes from T12 to L1. Okay. And for the vagina, it comes from the pudendal nerve, that is S2 to S4. We will see a little more in detail about the supply to the uterus in a later slide. So you have a preemie who is in labor. She is not able to tolerate labor pain. So she requests for an epidural analgesia as she wants labor free, she wants painless labor. So the anesthesiologist has come in and he is asking you that at what level you want me to block, give the epidural block so that you can offer her pain-free labor. The lowest level he wants to ask you, he does not want to block the higher levels because if it goes up, it can cause total spinal anesthesia. So the options were T10, T11, T12, L1, and L2. Now, if you have a look at the supply to the uterus, remember that for the uterus, the body of the uterus, the supply comes from T10 to L1. If you block T10, obviously, yes, the drug is going to spread downwards and you can have painless labor. Similarly, if you block T11 also, the pain will be blocked. T12 also, L1. Now, L1 is the lowest level. If you block, you can offer painless labor. If you go below L1, if you go and block L2 or L3, the lady is not going to have painless labor. Okay. So this is one part. This is during labor. Now, if you want to do some assisted vaginal birth, some procedures like you want to apply a rotational forceps or you want to apply a ventouse, is this epidural that you have given, is this going to be sufficient? It's not going to be sufficient. In addition, you either have to give a pudendal block if you are doing a mid-cavity procedure. If you are doing an outlet or low mid cavity, then you can just give perineal infiltration. Okay. So why do you have to give a pudendal block? Because you see the vagina or the out, it is supplied by the pudendal nerve, which is S2, S3, and S4. Okay. So you have to block the pudendal nerve whenever you want to do any assisted vaginal birth. You obviously have to know the lymphatic drainage. So the commonly asked question is, what is the lymphatic drainage of the cervix and the upper vagina? Options is internal iliac, external iliac, aortic. Then you have external iliac, internal iliac, common iliac, aortic lymph nodes, and you have external iliac, internal iliac, and obturator nodes. So the correct answer here is external iliac, internal iliac, and obturator. Now remember, the drainage of the cervix and upper vagina is the same. Whatever, and the lymphatic drainage of the lower vagina and the vulva is the same. Okay. So this is another very good slide. You can pause the video here and you can have a look at the slide so that you would remember the lymphatic drainage of the vulva, upper vagina, fundus, the fallopian tubes, and the ovaries. Now, this is a very favorite slide of mine because it's really very beautiful and it's a very helpful slide to remember the lymphatic drainage of the uterus. Okay. So this is the fundus, this is the isthmus, and this is the cervix. Okay. Now, this is the fundus, or this is the uppermost part of the uterus. So, from the uppermost part of the uterus, the lymph nodes, they go directly to the lymph nodes which are uppermost. These are the para-aortic or the pre-aortic lymph nodes. Okay, very easy to remember. Uppermost part of the uterus, they go directly to the uppermost lymph nodes. Now, from the isthmus. So, from the isthmus, first they go to the external iliac and then they go to the internal iliac. Okay. From the cornu, or they follow the round ligament and they drain to the superficial inguinal lymph nodes. Okay. And then from the cervix, okay. So from the lateral part of the cervix, they go to the internal iliac and external iliac. The posterior part of the cervix, they go to the sacral lymph nodes. So this picture, just keep in mind this picture, and it's really very helpful to know the lymphatic drainage of the uterus, cervix, and the tubes. And for the ovaries, they follow the lymphatic drainage of the tubes. So from the ovaries, they directly either go to the para-aortic lymph nodes and they can cross over the midline. Now coming to the fallopian tubes. Okay, so there are two fallopian tubes, they are 10 centimeter long, and there are various parts. So the first part, or the intramural part, this is the part that is embedded inside the uterus. Okay, so this is the most medial part. The length of this is around 1 centimeter and the width is 0.7 millimeters. Then after that, you have the isthmus. This isthmus, it is about 3 centimeters long and the width is 1 to 5 millimeters. Then you have the ampulla, which is the longest part of the tube, and also it is the most widest part. Okay, it is 1 centimeter wide. And then you have the infundibulum, and then you have the femoral end. So the most important question, or the frequently asked questions, is which is the part of the tube that is the narrowest? So traditionally, this intramural part, they will not consider it to be as a part of the tube because it is embedded inside into the uterus. So traditionally, it is thought that this isthmus, this is the part of the tube which is the narrowest part. Okay, so isthmus, remember, it is the narrowest part of the tube, and ampulla, it is the widest part. Another question that is asked is, which is the area or which is the part of the tube in which you are likely to get most ectopics? So ampullary part being the most widest, most of the ectopics, and this is also the length of the tube which is longest. It constitutes approximately half of the length of the tube. So it is, if the tube is 10 centimeters long, the ampulla is about 5 centimeters. Most of your ectopics tend to occur, or later ectopics, because this is the widest part of the tube, it is more distensible. So ectopics which occur later on, 6 weeks, 7 weeks, you are likely to find them in the ampullary region. A little bit about the microscopic appearance. So the tubes, they are smooth. You have the inner circular layer, you have the outer longitudinal layer, and then you have the mucous membrane inside the tubes, which is lineated columnar epithelium, and the cilia, they beat towards the uterus. Obviously, because the fibria, they are going to catch the ovum and they want to propel the ovum towards the uterine cavity. Okay, and yeah, so that's all about the uterine tubes. Now, next, coming to the ovary. In the ovaries, you have to remember what are the relations of the ovary. Okay. So if you remember this picture, I think it gives a very good idea about what are the relations of the ovary. So the superior or the tubal pole, it is covered by the fimbriae. and it is attached to the suspensory ligament of the ovary. The inferior pole, this is directed towards the body of the uterus, and it is attached to the uterus by the round ligament. Then you have the mesovarium, which is a double layer of peritoneum, and it secures the anterior border of the ovary to posterior part of the round ligament. So this is the round ligament. This yellow part is the round ligament, and this is the ovary. Okay, so whenever you open the uterus, whenever not to open the uterus, whenever you open the abdomen, remember, go in and see. You will see three structures, and the anterior most part will be the round ligament. Then you have the tubes, and then the posterior part you will have the ovary. Okay, so it is round ligament, tube, and ovary from anterior to posterior. Then the posterior surface of the ovary, it is open to the peritoneal cavity. The medial border is related to the uterosacral fold and the body of the uterus. And the lateral border is the angle of the internal and external iliac vessels. And then you have the ureteric fold and the obturator. So you have this ovary, which is lying in the ovarian fossa. What are the relations of this ovarian fossa? So superiorly, you have the external iliac artery and the vein. Anteriorly, there is the broad ligament of the uterus. Okay. Posteriorly, you have the ureter and the internal iliac artery and vein, and inferiorly, you have the obturator nerve, artery, and vein. You have to remember all these structures because commonly they would be giving you about 4 or 5 options, and they would ask you which of this is not related to the ovarian fossa. They can give you anything. They can give you the uterine artery, or they can give you the external iliac or the internal iliac, and you have to find out which of them which of them is either related to the ovarian fossa and okay. So that was all about the anatomy of the female reproductive tract, and I hope this video was helpful. Thank you once again for watching the video, and good luck for you for your exams. See you again next time. Thank you. Bye-bye.
Recording stopped.